Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
Good afternoon. My talk is about serotonin reuptake sites, serotonin receptors, and the neuroimaging revolution with functional PET providing high temporal resolution. So I'd like to ask the simple question. It's about the effects of SSRIs in the brain. Classical studies, a lot of classical studies have shown the distribution of the serotonin transporter, also the occupancy by SSRIs, and they use this data to predict treatment response and outcome. The big issue here, the drawback is, for clinical routine, you need this data for single patients, so the sensitivity and the specificity was not high enough. There's always a huge overlap regarding the distribution of receptor subtypes, but also regarding the specific molecular data. So we and others have shown that you can use occupancy data for prediction, but not with sufficient sensitivity and specificity for treatment response. So we need other technologies. In the serotonergic system, there are a lot of different receptor subtypes, about 14 different receptor subtypes, and we have radioligands available for at least 5 of them. So it's a quite good situation compared to other neurotransmitter systems. So the combination of fMRI or pseudocastle with molecular imaging using PET, I think it's a quite fantastic tool to overcome this limitation we have currently in clinical routine. Up to now, to the best of my knowledge, no imaging biomarker, functional or molecular biomarker, is really used in psychiatry regarding most of the disorders, depression, anxiety disorders, and so on. So there's a lack of predictors, a lack of biomarkers, and I think we can use imaging biomarkers, but the normally used imaging techniques are not sufficient up to now. So the combination is a quite interesting approach, and most of the studies up to now using, for instance, challenges, drug challenges during the fMRI paradigm during a period, for instance, of 60 or 90 minutes. And the idea is to predict long-term effects of study drugs, for instance, response from short-term influences on functional connectivity. These are quite good techniques. However, these techniques are also limited regarding sensitivity and specificity regarding the situation in a single patient. So we think that the next important step is to associate, to predict these changes in brain function or in brain connectivity, mostly based by bold fMRI, by target occupancy changes, and by receptor distribution models. So you can include in your models all these data we have about the topology of receptor subtypes. So the idea was that you have a long resting state period, you have the challenge during this period, and then you're looking at the changes in the connectivity, also the dynamics of the connectivity in association with your challenges, in the association with your PET data. So what we found is that these results are quite convincing, also as expected. For instance, a lower connectivity strength, some kind of uncoupling using resting state networks. We did also task-specific paradigms. But also in this case, the sensitivity and specificity was not high enough in a single patient. So the important point for the application in clinical routine is always the single patient economic data. So we have also provided a database with voxel-wise distribution. You can just go on our website and look on the target protein, and we can provide you with the distribution. It's not just on the quarterly side. That's just an overview showing more or less most popular genes regarding publication record. You can do this for more or less all different proteins. And based on this, you can produce much more sophisticated cluster networks or cluster approaches, providing topological differences regarding different pharmacological challenge. For instance, ketamine. In ketamine, not just the NMDA receptor is important, but also other receptor subtypes. And you can include, for instance, 5 different proteins and look on area-specific differences in the fMRI signal based on these distributions. So quite important, I think. We have, and others have now demonstrated this in conventional PET MR scanners with a temporal resolution of 2 minutes, 3 minutes. And the big advantage is that the task-specific changes are dramatically different regarding the effect size compared to fMRI, for instance. So especially if it comes to pharmaco-fMRI, retest variability is important and effect size is important. So also based on this, I think functional PET is a really important step.
Ladies and gentlemen, my name is Chen-Chia Lan. I'm a psychiatrist from Taiwan and a PhD candidate from Imperial College London. I'm very honored today to have the opportunity to share with you on the topic, mu-opioid receptor availability and functional connectivity during reward processing in gambling disorder. I have nothing to disclose, and the following presentation is based on my PhD work. I would like to thank Professor David Nutt, Dr. Matt Wall, and Dr. Jim Myers, one of my supervisors, providing excellent support and guidance. I would also like to thank Professor Ann Lifford Hughes and Dr. David Arizzo for kindly allowing me to do an exploratory analysis on the PET and MR data they have collected from gambling disorder patients. Gambling disorder, originally called pathological gambling in DSM-4 and was classified as one of the impulse control disorders, has been renamed gambling disorder in DSM-5, released in 2013, and was reclassified as one of the substance-related and addictive disorders. This is a very important concept change that gambling disorder has become a behavior addiction. This gives us a great opportunity to disentangle alterations associated with addiction itself, rather than those that might be associated with the toxic effects of various substances used in substance addictions. There is a very interesting phenomenon of psychopathology observed in gambling disorder patients, gambling-related cognitive distortion. This could be exemplified in the Gambling-Related Cognitive Scale, GRCS. There are 5 subscales. The first one, interpretive bias. For instance, a gambler might attribute his win to his skill sets rather than probability. Illusion of control. A gambler might believe it was his special rituals that dictates gambling outcome. Predictive control. The gambler might predict he'll win the next time after a streak of losses. Gambling-related expectancies. A gambler might feel very happy when he's gambling and feel he could not function at all when he's not. Perceived inability to stop gambling. This signifies impaired control in gambling involvement in disordered patients. In gambling disorder, we would like to find out whether there are associations between gambling-related cognitive distortion, the mu-opioid system, and the brain activity during reward processing. In terms of the fMRI task to study reward processing, we have adopted the monetary incentive delay task the MID task, originally developed by Professor Knudsen. There are 3 different kinds of trials repeatedly occurring during the whole MID task session. The subject will first see a 1-second cue screen, either an upward arrow, a downward arrow, or a negative sign, followed by a 2 to 4 second blank screen before a target sign with a star on it appears in the screen. The subject has to respond to this target sign as quickly as possible by hitting a button to hit the target. Finally, an outcome screen will appear and indicate whether the subject has actually hit or missed the target. During the winning trials, indicated by the upper arrow, the subject will actually win money if it hit the target. In loss trials, indicated by the downward arrow, the subject will actually lose money if he missed the target. In neutral trials, indicated by the negative sign, the subject will not win or lose money, no matter he hit or missed the target. In each trial, it could be further divided into the anticipation period and the outcome period. The anticipation period starts from the emergence of the cue screen until the emergence of the target sign. We are interested in the anticipation period, especially between the contrast of winning trials versus neutral trials. So the win anticipation versus neutral anticipation contrast. This contrast has been shown to robustly activate brain regions associated with reward processing. So using a figure to depict the associations we're trying to find out, is there are 2 functional connectivities as shown in the red lines. So the first one, nucleus accumbens and anterior insula functional connectivity, would be compared against their 2 endpoints. So the BPND in the nucleus accumbens and anterior insula BPND. And the second functional connectivity, the nucleus accumbens and posterior insula functional connectivity, would be compared against the BPND in its 2 endpoints, the nucleus accumbens and the posterior insula. So here are the results of the PET and MR combination analysis. The 2 figures below, the x-axis are NACC BPND in the figure on the left, or anterior insula BPND in the figure on the right. The y-axis represents the functional connectivity between the nucleus accumbens and anterior insula. We could see that there is significant negative association, negative correlation between NACC BPND and the functional connectivity between nucleus accumbens and anterior insula. In the figure on the right, there is no association between this functional connectivity and the BPND anterior insula. In summary, the mu-opioid receptor availability may affect the functional connectivity between the nucleus accumbens and both anterior and posterior insula. However, there were no significant associations found between the GRCS total score and the mu-opioid receptor availability or the functional connectivity between the nucleus accumbens and the insula. Limitations and future directions. This study may be limited by the small sample size, only 14 gambling disorder patients, and the sequential rather than simultaneous acquisition of the PET and MR brain images. So although the sequential acquisition of the PET and MR data might just be hours apart, one may still argue that the data don't exactly reflect the same brain states. So further studies may try to utilize simultaneous PET and MR with inherent temporal synchronization and spatial alignment, or pharmacological intervention studies with fMRI tasks designed specifically for probing into the gambling-related cognitive distortions. And this may further clarify the association between cognitive distortions, the mu-opioid system, and the functional interactions between the nucleus accumbens and the insula or other brain regions we are interested in.